Good morning, everyone. Guys over here. Let's make sure everybody's aware. We've got an in-person course coming up February 10th and 11th. It's the lower quarter course, former R2P folk, Dr. Carly Calsey and Dr. Kelly Henry will be hosting me at their facility in Seattle, Washington. So it will be lovely to see you guys there. Welcome over here on Facebook Live. You folks on Facebook Live that aren't members, you can join us over here and get your questions answered, like Alex and Glenn and RJ and others that will be joining here in a moment. We do this every week. This is a case study thing that I think is helpful. Is it helpful in trying to figure out how to integrate this neurocentric approach into your clinical practice? And yeah, mostly I think it's kind of a just almost like looking at the same things we've always looked at, but you just kind of tilt your head and squint and, and look at it through a slightly different lens and just make sure that certain things are off the table before we start working. Good morning, Dr. Davies. It's been a minute since I've seen you, maybe 20 years worth of minutes. I hope you're well, Doug. So we do have a case, a course coming up, the lower quarter course in Seattle, February 10th and 11th. For those of you that are interested, I'm also going to be going just as an observer and friendly and to enjoy friendly convivial times at the R2P symposium in Dallas, which is the weekend before. If anybody wants to join, we can have lovely times and talk shop and all that stuff. The other thing that's worth noting for those of you just getting on here, we do have what I refer to as the Online Academy, the NeuroCentric Approach Online Academy. Currently is 35 plus hours of online continuing education. It's PACE accredited for you chiros, and it for CE for you chiros. It is growing all the time. And if you were a lifetime member there, which unfortunately, those of you that haven't become a lifetime member yet, that portal has closed for the time being. But lifetime members get $100 off of our in-person courses. And candidly, if you're on this call right now, I'll do a flash sale. If you're interested in attending the course in person and you're bummed about the fact that you can't get a lifetime membership, then bug me and I'll hook you up. All right. So the Online Academy, the links for that, for those of you on Facebook over here, are should be up on your screen. The link to both the Online Academy and or the link to the in-person course. If not through the in-person course and they're on the NeuroCentric Approach website, you can find links to the Academy as well. All right. So I got at least 2 cases today that I had in the past week that I found fascinating. I hope you guys are finding this stuff fascinating too. Even after 20 years, it's I still get a smile on my face in working with these cases. I was talking with a patient earlier today that it's kind of fascinating that, you know, at this stage, I rarely get softballs in cases that come in, and yet the cool vibe about it, when you got a patient that's seen, you know, half a dozen or more providers of varying ilks, and they come in, I find that, you know, it's a collaborative process really with the patient. They're very much more into the learning process. They want to know as much as they can. And quite honestly, they don't expect a hell of a lot. Often they're very cynical. It's a curious mixture of cynicism and hope. And the cool part, and part of what I like about what we've done with the neurocentric approach and the clinical audit process embedded within that, is you can show the patient right then and there, either this dog hunts or this dog doesn't hunt. And if they've got something that they can do that's painful, or that you can do to them that reproduces their symptoms, and then based on your findings, you can apply an intervention from our systems-based analysis kind of perspective, perturb their system and see how it responds, and they respond favorably, then it's very apparent to both of you right then and there. And that gets a person a little more hopeful, gets them involved in their homework. So I find that their compliance with the home exercise plan is typically quite good. Before I launch right into the course, the case study today, we do have Dr. Glenn Harris of MSK Plus, who is on with us today. Glenn, you got your ears on? If you do, let's get you to unmute.
Hey, folks.
Hey, there you are, Glenn. Glenn, you've got a lovely virtual course that you've got lined up, sort of like an online symposium. That's a fascinating sort of reflection back on the historic Mixter and Barr paper from what, 1934, was it?
Yeah, the 90-year anniversary is coming up. So MSK Plus has decided to bring a lot of people from the disc world. Several chat about assessing and managing patients that have discogenic back pain with and without radiculopathy.
Very good. So where can folks find information about that particular course, Glenn?
So they can go to the msk-plus.ca website. I'll put it in the chat afterwards.
Thank you.
Or they can follow us on any of the Instagram or Facebook. We have the hyperlinks are located on those places.
Very good. And you cut out there for just a moment when you were initially announcing it. I think some of you folks know that Glenn's been kind enough to ask me to join in on that, and I'll be presenting at that. Who are some of the other people that are going to be on there, Glenn?
Yeah, so we have Dr. Kathy Dooley's going to give us a recap of the relevant anatomy to the IVF and the disc, particularly looking at the structures that can refer into the leg and perhaps mimic radiculopathy. We have Dr. Varsha Kumar, radiologist, is going to review some of the radiology features of the disc assessment and radiculopathy. Stuart McGill is going to present on the disc mechanics and building resiliency. Mark Irwin's going to present his research and his thoughts on the degenerative disc process. Dr. Cox is going to present the assessment with particular focus on flexion distraction. Yourself is going to assess the patient and talk to us about symptom modification procedures, perhaps with discogenic flexion intolerant patients with and without leg pain. And then we're going to have a little bit of a discussion at the end, particularly looking at the debate between whether you should manipulate somebody with a disc herniation with or without radiculopathy, or whether you should not manipulate those patients. That'll be an interesting discussion.
Yeah, I agree. I think that'll be a lot of fun. This I like what you're doing with this, Glenn. This is the kind of thing I remember 2010, I went to a course down in Naples, Florida. It was Stu McGill and Pavel Kolaj, and it was like a head-to-head. There were only like 40 docs in the room at the time, and they were kind of put very much on the spot. They were given two patients over a 2-day period to assess live in front of the audience. The two patients, one was an Olympic sprinter for the US and the other was a UFC fighter. And they were both assessed by Stu McGill and Pavel Collage, each naive to each other's prior assessments. They would assess, leave the room, the other would assess, the first would come back in, they presented their findings, they provided a diagnosis and a treatment plan, and then fielded a couple of questions, and then the other did the same, and then they had to come back into the room. And what do you reckon happened? They basically found the same thing, like a good clinician probably should. And they just had slightly different roads to Rome in the process, and in the process of describing an etiology and a treatment plan. It was an absolute delight. And Stu, in talking with him later, he said, "Phil, I've never been as scared in my life." That was kind of interesting. I think it was one of the first times I'd met Stu, and he and I had collaborated quite a bit up to that point, because Stu had helped me get out of my mess when I herniated a disc in my back, and we got to know each other relatively well prior to that. But yeah, we were having a couple of beers afterward. I was scared shitless, Philip. And it was very very humbling and lovely to hear someone that I hold to that degree of esteem as Stu McGill speak that candidly. So I very much look forward to this, Glenn. I appreciate you putting it together, and you folks, MSK Plus, look for the links there in the chat. Those of you that are members on the recording and everything here, and those of you over on Facebook Live, Glenn, you might even go over to my page on Facebook Live and drop a link there.
Sounds good. Sounds good.
Here on Facebook can find it. Okie doke. Thank you,
right,
brother.
thanks, Phil.
Right on. So let's get on with our case studies this week, since that's the nuts and bolts of why we show up, in addition to conviviality, commerce, and coffee. Ooh, how about that for a 3C alliteration? He's on fire today. All right, I am going to move over to HIPAA compliant adjusted EMR Jane app. For those of you that don't use it, you really should. One of the best things I've found in my practice in 20 years. Great EMR. Allison Taylor did a great job of putting this together. Fine Vancouver, BC product. So our first patient is a 44-year-old female para student educator. She mostly works with kindergartner folks in the public school, kindergartner kids in the public school system. Often these are kids with behavioral difficulties, and she included her own children in that mix, and that was part of the reason why she got involved with it. She arrived with a history of 6 years of low back pain and buttock pain, but particularly radiation of pain into the right lateral thigh, to the anterior thigh, to the anterior knee, of insidious onset. As I said, began about 6 years ago, and it is worse with prolonged sitting, worse with all recumbent postures, but especially left lateral sideline, where she described that the time where she feels that most is laying down with her youngest child at night and reading. So this is a somewhat of a difficult time for her. Now we're thinking about top-down processes that are involved in this from a neurocentric approach. She finds it somewhat saddening that she lays down to have a lovely, tender moment with her child, and pain gets in the way of her feeling that, because she'll feel a 7 to 8 out of 10 pain laying in that position. Despite 6 years of having this, despite having seen multiple chiros and multiple physical therapists, she was referred over to me by her naturopath. She's not actually received a diagnosis of what is going on. She finds generally that static postures make her symptoms worse, whether sitting or standing. She noted that exercise helped, quote, unquote, tremendously. And she walks a lot. And I would qualify that by saying she walks frequently, not typically much more than a quarter mile with her dog, because walking more than 3 miles markedly increases the pain in the right leg. She describes that right anterior and lateral thigh pain as hot pain. Currently, at the moment when I saw her, it was a 5/10 in severity. And she also had secondary symptoms of bilateral shoulder pain, right, much worse than the left. And she described a sort of locking in the shoulder with some overhead movement with external rotation of the arm and abduction of the humerus. So we put that on the laundry list as well. She also noted that frequently she will experience bilateral numbness and tingling in all 5 fingertips. So we got a multidermatomal presentation in the upper extremity. In going through her intake, some of the things that I noted was, one, on her PHQ-2, her two-question depression screen, she was negative ×2 on that. But she also noted in her medication that she was on Lamictal, and that is typically often prescribed for people with bipolar disorder. So I leaned into that a little bit. She didn't note any family medical history of mental health issues, but she revealed that she had had some light diagnoses or a mild diagnosis of bipolar disorder that had been a number of years since she had swung back and forth on that, and that it was well controlled with Lamictal. And she also had found quite a bit of help by doing mindfulness yoga, mindfulness meditation, training, retreat, even teacher training, a lot of yoga, music, outdoor time, and spending time with her dog. So she felt like she was controlling things very well on that. She even volunteered that she didn't feel like she had any prior history of trauma, which had been uncovered or latent, that she had considered that as a possibility given her history and given her reading into this particular subject matter. She didn't have any recognition of anything like that. Although she did note, as she thought about it, that the only thing traumatic that she could recall, this is a fascinating thing about doing a detailed history here, guys, because this wasn't written down, that when she was a young girl, she had a hemangioma on her right lateral thigh. Remember, her right leg is the affected leg, and the right leg symptoms that she feels is a hot burning pain along the lateral aspect of the thigh. And I asked her to point to where the hemangioma was, and she points right dead center in the middle of the course of the peripheral neurology that goes through there. So now my antennae are up. And I said, well, what was this about the hemangioma? She said, well, it became infected and it had to be surgically excised. And she subsequently got an infection. and the infection resulted in needing her father to vigorously scrub this wound with an antibiotic topical on a daily basis for weeks. And she said it was very painful, and that she had a very well-formed scar there, but she hadn't really thought about it as being involved in any of this. And she noted that none of her prior practitioners had investigated that or noted it. She's been getting regular massage. She said that massage therapists had worked around the scar, but never on it. They had worked up in the hip, mostly thinking that this was a sciatica kind of situation. So my interest was quite piqued with that. And quite honestly, after looking at her intake, I walked into the meeting with a high bias that this was going to be another relatively uncomplicated flexion intolerant back kind of situation with an underexplored lumbar disc issue. So we launched into our physical exam. And as you guys know from the online coursework, the physical examination for the lower quarter tends to be relatively consistent. Those of you that have done the Fix Your Own Back course are familiar with that as well. As I had her go through her trunk ranges of motion, flexion was mildly limited, but no pain at CC. Extension was mildly limited, but no pain at CC. When she did left rotation, it was mildly limited, but she had pain. It reproduced her CC pain in the right lateral thigh. So we stayed there, and I even gave her a little bit of overpressure into the rotation, and her symptoms steadily got worse. And she said, yep, there's my pain. That is the pain that I've been having in the right leg when I have it. So since I've got her standing right there and my hands are already on her, this is different than you guys that are members. This is different than you've been trained in the online course work with the graded neurological evaluation, or GNE, that we perform. Rather than, we've already done our brain-based stuff, considering things in the history that might be associated with that, considering things in her systemic overall health that might be involved in this. The next place we would typically go would be the spinal cord nerve root IVF interface. But since I've got her standing right there in her CC, and I've got this scar thing now on my brain, I said, brought her back to neutral. And I said, okay, let's try a little something. And I palpated along the side of her leg. She was still clothed. And I put my hand over the area where I felt like the scar was. And I said, is that it? And she said, yep, that's it. And I could feel the induration there over the scar. And it was about yay big, size of a tennis ball or so. I guess that's what, 8-9 centimeters or so. And I did a quick DTM, dermal traction method, or yank away pain, for those of you that are in the know. I reached over that area and gathered it up with my fingers, and then lifted, kind of squeezed the tissue together and lifted to create a different theoretically, different mechanical interface of any putatively entrapped neurology within that area, and see if it helped. And she turned to the left and she gave me that look that many of you know already that we see in patients when that happens, that, wait, what? And she goes further, and without having pain or having a marked reduction in pain, she says, wow, that feels a lot better. And she immediately said, no one's ever done that. And I just lifted it up, and we did several rotations into that, and it stayed about 50% improved. And then I took my hand off and had her do it several times more without my hand there. And she reported continued 50% improvement in the pain that she had felt with that. So we try not to get too caught up in the process. It's cool when we see that on the periphery, but remember, guys, we got to rule out things centrally as well. So I try to check my biases. Heart gets a little bit racy. You're like, cool, I found something. You start to think you're cool. Your ego gets involved, all that fun stuff. Check all of that crap and then keep collecting your data. So we go over and we do the motor portion of the examination, repetitive single leg, heel, and single leg toe stands, and repetitive single leg sit to stands. And she didn't show me any deficits on anything except she could not do a single sit to stand with her right leg because she felt both pain and weakness. Okay, so that's always sketchy territory because pain will shut down the ability to do the movement very well. You'll get those endurance athlete warriors that are well accustomed to prolonged exposure to pain that'll just plow through it perhaps. But for most people, when they get a really sharp pain, especially it's a nerve origin, it's very difficult to press on with that movement. So we continued on with our examination. The slump test and the seated compression test were negative. There was no asymmetry from side to side along the sciatic tract. But when I put her in sideline, what do you think I found in that femoral nerve tension test? Femoral nerve tension test reproduced the CC pain in the thigh, which I didn't find to be overly interesting because I expected that we had a neural component that was peripheral at that point. And you know that at that particular area, the neurology is of femoral nerve origin or upper lumbar origin. So then after doing the rule outs for instability syndromes and the rule outs for SI involvement with Laslett cluster, we flip her over into prone. We do a palpation of the interspinous spaces, and she's tender at L3-4, at L4-5, and L5-S1. So we already had one index, which was a standing rotation, but in her history, she said sideline was also provocative. So before I start to try to do anything else cool, I wanted to see if I could get another index test to compare. So I asked her, how long does it take for you to lay on your left side before your symptoms come on? And she said, only about a minute. I said, okay, so we've got that much time. So we laid her on her side. I took close note of what position she was laying in and how her legs were organized, and I put a watch on it. And it took 1 minute and 20 seconds before she reported her symptoms came on. So then we laid her face down, and I had her to do prone press ups. So now we're moving into the most common MDT kind of rule outs with repetitive end range loading and extension. Now I'm suspicious of a femoral nerve issue and a possible upper lumbar issue. So remember that if we've got a very hot femoral nerve, we put somebody into repetitive extension like that, sometimes it'll fire up their symptoms in the leg. However, the putative disc mechanics in some people will cause nuclear migration, we think, into, sorry about that, I had somebody else that was on, that was coming into the chat room there. Welcome on board, Mark. So when she's doing her prone press up, I fully expected that she was going to show up with a flare up of her symptoms, which she didn't. But remember, in people that still have something of hydraulic effect, you might say, of the nuclear material, as they do repetitive end-range extensions, if that disc still has some integrity in it, we can get nuclear migration. That's why we have some papers that say that nuclear migration does happen with those end-range loading maneuvers, and some that say that it doesn't, because everybody ain't the same, and this phenomenology changes over time. Hopefully in that program, Glenn, we can talk some about that with Stu and some of those others about how the disc changes over time and its morphology. And maybe Jerome, you're on here today, Jerome Fryer for Dynamic Disc Designs. You might weigh in on that too when we're done here and go to the Q&A. So we do 20 prone press ups, and I have her stand back up and twist to the left, and she experiences now 75% improvement in pain with that. I have her to lay back down on her side and go into the sideline position that was previously provocative. We put a watch on it, and she can now lay there for 3.5 minutes after doing that. Okay, so I'm now working a theory that we have an observed femoral nerve tract that is overly sensitive, and potentially the motor is disturbed as well. So I go in, and that is originating at the spine, and that downstream we have a complicating presentation of this historical scar right over some of the involved neurology. Now, remember that you could go in and do manual therapy over that scar and probably help. But as long as there is something potentially going on upstream at the spine and you're not treating that, then your ability to make a real change in that patient's condition is going to be probably temporary at best. So that particular condition made me wonder if her motor might improve. And lo and behold, we sat her down on the end of the bench and repeated the sit to stand on that right leg, and she got a rep, and then she got 2 reps, and then she got 3 reps. And she said the pain is starting to come back on. So I did just a little bit of DTM over the area again, and she got 2 more reps out without pain. Okay, so that's relatively nice and tidy to my biases associated with neurocentric approach. So that seemed to be a pretty solid case of an NCA kind of score for the win. This could have early on, when I started looking at it, could have fit originally a lumbar disc, lower lumbar disc issue that was presenting as a sciatica complaint, and could have had a main syndrome, kind of thoracolumbar syndrome sort of issue going on. That did not show up. It could have been, if I had done what a lot of my folks that jumped early on the YAP and DTM train and got very mesmerized by the coolness of being able to modulate pain by changing the local environment around a putatively hot peripheral nerve. I could have gotten mesmerized by that, but all 3 of these, according to my biases going into this and early on in the course of treating the patient, all 3 of those were essentially red herrings. So as I continued on with this, it looked like we had one of those unusual upper lumbar disc issues. Now, we got to lean on the evidence here, right, guys? If a person is dealing with a lumbar disc, in any sort of symptomatic fashion, the vast majority of those occur at L4-5 and L5-S1. The vast majority meaning like 95% of them, literally, statistically. But if you're going to do this kind of stuff, you're going to start getting more upper lumbar, not because your bias is there, but because your reputation gets out. And people that have this, remarkably, because they're probably in a 5th percentile, nobody else is looking at it. Nobody else is looking for it. Some of the biggest fixes that I've had and the people that have come the furthest to see me, I remember one guy early on in my practice that flew down from Alaska, and within 20 minutes in the exam is 20 years of pain. We were able to put a stop to it very quickly by treating it like an upper lumbar disc. And he was furious that no one had ever looked at that particular area. So keep that on your radar. Know that as you walk this little NCA path and your name gets out there as being a little more proficient at dealing with some of these weird neuro issues, you're probably more likely to see some of these. Your selection of patients is going to sort of shift in that direction. Now, before we jump off of this case, in the last few minutes, remember she had a secondary issue of bilateral shoulder pain, some locking in the right shoulder, typically with arms up. So I very briefly asked her for an index movement, and she showed me this. She did abduction with the elbow bent, abduction to 90 degrees, and she had pain in the superior and superior posterior aspect of the shoulder. So I did what you guys will see at some point in the in-person courses for the upper quarter course of NCA. I got on the bench behind her and provided traction of her cervical spine. I had her to drop the arm, traction the cervical spine, and she raised her arm again to where she expected it to hurt, and she stopped, and then she started going higher. And you'll see that often as well. The body anticipates that pain. It's like a stone in the middle of a flowing river or a flowing stream, and the body starts to flow movement around that anticipated painful spot. So she, that point, thinking that there's some neuro that's involved, that it probably has a spinal origin, but not having time to go in and do a whole bunch there, I very briefly went to the most likely peripheral nerve that would come off of the spine that would service that aspect of the shoulder, the posterior and superior aspect of the shoulder. And remember that the suprascapular nerve is the innervation to the posterior third of the capsule, and it is the motor to the infraspinatus and supraspinatus, and it is vulnerable to entrapment syndromes just beneath the upper trapezius on the lateral aspect of the supraclavicular notch, and at the transverse ligament at the suprascapular notch, where it does a little 90-degree turn, essentially, right in that area. So I got on, you guys can put your hands on your own clavicle right now and palpate laterally until you get to the end of the clavicle where it runs into the scapula, and drop down in that little corner and palpate right there, and then work slightly medially just in front of the trapezius right there. And now you're right over the suprascapular nerve and the supraspinatus. And if you ping back and forth on that, you might be able to actually feel that. I see Mark wincing a little bit already as he's doing it. So you might be able to feel that, one, that's a bit uncomfortable. And two, if you do that and you had prior pain with elevation of the shoulder, you might find that as you do transverse nerve mobilization and shove that nerve laterally a bit, try to change that mechanical relationship, you might get some improvement there in that pain. And indeed, she did. She had more improvement there. But similar to what we observed in her back, it looks like we've got a peripheral issue, we've got an entrapment area that's known, and we've got some cervical stuff. So what I sent her home with, cervical retractions, to start working on that. We'll better evaluate that at our next visit this week, I think. We will also, and she also got a script of another McKenzie intervention since we had improvements with prone press ups. I put her on that. And I also put her on DTM for the lateral femoral cutaneous nerve, but green lit her to work around the thigh wherever she found it to be symptomatic. So remember, the anterior femoral cutaneous nerves, several of them pop out there in various little areas, and they are highly different from individual to individual. Okie doke. So there's the primary case study for the week. You guys have any questions or comments with that particular case? For those of you over here on the Zoom meeting, jump right in and throw either raise your hand or put something in the chat room, and I will respond to you, and we can answer any questions if they're there. Jerome, do you have any input on that change of the nuclear and annular mechanical properties over time that you've observed in some of your work in making your excellent models at Dynamic Disc Designs?
Hey, Phil, can you hear me?
I sure can, Jerome. I think everyone else here.
Yeah, like you said, the literature, it really depends on, the subjects you're testing. So you're going to get mixed results in the literature. But I thought just to kind of help people maybe understand, I've developed the nucleus pulposus.
Oh, that's awesome. Awesome.
It took me a long time, and I've had feedback from surgeons. I've been to surgical meetings, and I actually traded a model for a this is kind of fun. I didn't have alligator forceps, which is a surgical tool that they use to extract the nucleus, right? This keeps pulsing here for whatever reason, but so I traded a model with an adjacent exhibitor. I said, hey, would you like one of these models? I need one of these. Didn't have any money, so I just traded a model for a surgical instrument. So anyways, and then I also stopped some top surgeons at NAS, and I said, hello, Dr. Pollock. I'm Jerome Fryer. I'm developing the nucleus. Do you mind if I get some feedback from you regarding the actual texture and realistic feedback using these alligator forceps? And he's like, absolutely. So he put down his clipboard. But anyways, bottom line, I could talk forever about how I developed this, but the nucleus will move if it can, and if it's allowed. It's if there is no nucleus, and the disc is more homogeneous because of degenerative changes, well, it's not going to migrate. And will it stay in the place that you intended to migrate it to? That's another question. So look at look at this, right? So
they agreed that the stickiness that you're modeling there is
yes,
that sticky consistency is there as well.
yeah, it does.
I did not know that. That is
Yeah,
cool as hell. All right.
yeah,
All right. You
yeah.
guys would never get this anywhere else. neither any
Hey,
other back program and neither any other model maker. This is awesome, Jerome. Thank you.
so, and and people talk about, the core. Well, here's the core. That's the core right there.
Yeah, it is. The analogy I've always used has been an egg white, because people have or even salmon skin or something. But what we're essentially, my understanding, you correct me if I'm wrong here, Jerome, but my understanding is the proteoglycans and the aggregans, when exposed to the oxidative stress of multiple injuries to the tissues around there, will essentially denature, and that's what causes the change in the mechanical properties and the stiffening of that nuclear material to where it gets to be, something that looks like that crab meat thing that we hear about over time. So, and then I, suggest that, well, how an egg white, when you crack an egg and the egg white is raw, has a very different mechanical property than it does after you've put it on a skillet for a few minutes, a hot skillet for a few minutes. So that change, if that conversation needs to happen with the patient, and the ability for the change to occur with end range loading is worth them understanding. And I'll sometimes use that as an example.
Yeah, whatever a practitioner is comfortable talking about. If you like talking about food, then talk about eggs if you want, So I won't take up too much time, but actually I've just developed, now you're talking about an upper lumbar disc related problem. I had a customer in Australia say, I'm building the lumbopelvic model. He said, could you, put in a grade 1 spondylolisthesis? And I'm like, it's a lot of work. So over my Christmas break, I developed a grade 1 spondy. I've pulled off the posterior elements here, and I've actually developed the PLL as well. So you can see that. So I think it's the first model to actually demonstrate that. Now this is L1, 2, 3. You can see here is a grade 1 non-lytic spondy.
Sweet.
Right. And then up here at L1, 2, under flexion load, you can see that red nucleus extruding, right?
Right.
So, and then, of course, with the therapy that you induced there with that one patient, you went into extension. It was extension prone press ups, right?
Correct.
Yeah, and that's gonna, if you think about this is gonna create low pressure anteriorly because these two vertebral bodies are they're stretching away from one another, so it's going to create a proposed vacuum. And even in the model here, compression, right, and extension, you can see how the nucleus will actually track anterior because there is nucleus in here, and there's enough disc space to allow one to create enough decompression anteriorly here. So there's a lot of stages and states of the motion segment that will allow or disallow the nucleus to migrate. So anyways, I thought I'd just share that with you because actually I've just developed this, and I'll be putting it on L4-5 in the pelvis here shortly.
That's incredible, Jerome. Thank you so much for showing that. I learned some cool stuff today. That's very neat. I do want to comment though that by showing that red nuclear material, Jerome, you're clearly
Oh,
trigger
yes.
a nocibic response here. I mean, your patients
Oh,
just explode in front of you in fear
straight,
and loathing. Oh my
straight to the
God.
psychologist, right?
Yeah.
Straight to the
Yeah.
psychologist, like just beeline it.
I don't want to beat up too much on our brain-based brethren and
Yes.
sisters out there. This stuff is
Right.
real, right? No,
Yeah,
totally
exactly.
real. But it has fascinated me over the years how um, the the often the same people that are really pushing that as the primary thing that is causing pain in most people. I would venture to say that it is present in most people, but it is not primary in most people. The Another term that is often bandied about is infantilizing, that we infantilize our patients by some of this stuff. Well, I look at that and say, if I knew what you just showed me, if you told me that in a clinical encounter, yeah, it might scare me a little bit, but then you have a responsibility to do the same thing that you just did beautifully, Jerome. You show the pathology and then you show the fix. And you're telling the patient, teaching the patient how to make the fix themselves. So you're empowering them and giving them agency. Now, wouldn't you be infantilizing them if you just didn't show them any of these scary things that actually probably are going on in their body? I would say yes, you would be. And the analogy I would give to my patients is, if you got a 2-year-old that's scared of clowns, then you probably just avoid clowns, right? You don't talk about clowns with your 2-year-old. But at some point, maybe when they're 3 or 4, you're going to say, all right, let's have a talk about clowns. Here's what clowns do that are cool. Here's what clowns do that's not so cool. Clowns at the circus, they're going to be a lot of fun, but clowns in a movie staring at you out of a gutter are probably not the clowns you want to associate with. So you give them education as they develop a more nuanced understanding of what's going on there. So that'd be my 2 cents worth in that whole dynamic that's going on out there.
Philip, can I share a couple of little mini case things here?
Absolutely, Mark. Go for it.
So first is, I'm 74 years old, but I'm convinced that my disc still has some of that mobility. And unfortunately, I have discogenic pain. And recently it shifted over to the right. And I was left antalgic. And I found that the Mackenzie side bend was helpful as well as extension. So that, and I guess I'm a little older than that. Usually people are going to be pretty darn stiff there. So the other case, I had just after I finished watching the ankle foot online class, I had the opportunity to treat a friend of mine who's a physical therapist, and he has this weird front of the foot, bottom of the foot pain. And, he had no low back complaints, no history of anything discogenic. But because I was going through the exam as you presented it, I tested him, and he had L5 dorsiflexion weakness on that side. And he didn't respond to extension. He did respond to the lumbar nerve opener. And it was really interesting because it isn't something that either of us expected. And some combination of doing that and doing some DTM around various nerve places in the foot seemed to change his pain level. He had this interesting thing where on that foot in particular, the metatarsal arch was completely dropped, and he had a big callus right under the middle of the foot, which he didn't have on the other side. And this was the side that had pain. So I taped that with kinesio tape and leukotape and showed him how to tape it himself. But it was really interesting to see that even though I didn't expect the spinal component, it was obviously there and significant. So anyway.
Yeah, that's really good case convo there as well. And you recall too from the fix your own back stuff that I talked about, that all too often it seems when we have patients that have the kind of observable, we'll call it biomechanical issues that you just described with the loss of the transverse arch, then we're kind of taught in school that meat-based approach that, okay, we've got some sort of biomechanical problem here that we need to intervene with maybe a metatarsal pad there or some sort of orthotic of sorts. But another way of looking at that, going back upstream to causation, is what is the actual innervation of the involved musculature that holds up that arch? And if it is compromised upstream somewhere in that course of those nerves, then you'll have some motor issues with that. So yeah, that's potentially a thing there. All right. Cool stuff here. You're welcome, Nathaniel. It's nice to see you here. So I've got one other, I will note that, Mark, you reminded me, this particular patient, I also trialed for her HEP, home exercise program. I trialed a static opener, and she had pretty high Q angle as well. And read wide pelvis. And I fully did not expect it to help because the involved peripheral neurology, when you put someone in a static opener with that leg up top, is going to be really drawn down tight. And one of the things that we noted in the exam was anytime she used the muscles of the quads for a prolonged period of time, her symptoms got worse. And anytime we put her in a position that pulled the tissues around that peripheral nerve down tight, her symptoms got worse. So I went ahead anyway to do the the empirical eval, put her in a static opener to open that putatively congested neural foramen at L3-4 most likely, and it worsened her symptoms. So we stayed with the what we observed to be helpful with the McKenzie prone press ups. So I think what I'll do, given that we've only got a couple more minutes, is I'll just set the stage for possibly another case next week, unless I have something that's more interesting that comes up this week in clinic. But I had a woman, another one referred over by a naturopath that had bilateral lateral leg pain, no numbness, tingling, or weakness, noted no groin paresthesias, but had urinary incontinence since 2 difficult vaginal deliveries 4 and 7 years before. Always the most flexible in the room. And we'll maybe talk about this one as well. It would be fun to have some of those like Mark and Jerome and others that have been in practice for a good number of years, and to see if you've observed the same thing that I have, that these people with constitutional hypermobility. She noted that she'd always been the most flexible one in the room. She's had chronic pain as long as she could remember. She manages it primarily with cannabis. She has seen a lot of different docs, has a family history of autoimmune disorders, rheumatoid arthritis. She's got migraine headache. She's got low blood pressure. And these things often are part of a constellation of symptoms in people with generalized hypermobility disorder. And she was 9/9 on her Brighton exam. But the one thing that I would be interested in hearing from some of you other docs that have been in practice for a good number of years, I've noticed that you can it's almost like your spidey sense comes up when you see a person that has generalized hypermobility, and you can look at them and tell. And I've tried to get inside that over the years of what exactly do I think I'm picking up, because I can see it in the history, as I'm taking the history and I'm just looking at their face, and then it comes up in a physical exam. And what I've noticed is almost a bluish pallor and a doughy kind of consistency to the skin and the face, and a lack of wrinkling that we would often see in patients. So sometimes they look quite a bit younger than their chronological age might be, and such. But in this particular patient, yeah, she turned out to be something that I noticed in the very first fix your own back course that I taught. The model that I brought up to the front of the room had the same thing. They had constitutional hypermobility, no prior history of disc injury to the back, no prior history of back issues. But when I put them in a seated slump or an SLR, or seated slump, but not SLR, so seated slump would produce their symptoms of numbness, tingling in the legs. In this particular patient, she had bilateral foot numbness and tingling, but it was multidermatomal, and she noted that she had prior diagnosis of Raynaud's syndrome, and she would observe that when she would get cold, that she would get the numbness in her feet. So she was trying to figure out whether it was vascular or not. And she had had a lot of vascular surgery for in her legs for venous varicosities. So I did my neuro exam and was able to reproduce her symptoms with the seated slump test, but not with the SLR. And her symptoms were multidermatomal though. And then I tested her dorsal and pedal pulses, and they were strong. Her capillary refill rate was good. And based on her symptom profile, I'm leaning towards this is probably someone that has Ehlers-Danlos. I'm not qualified. I'm not a rheumatologist to provide that diagnosis. And I had to go back and do a review of the literature, and we still don't have a clinical diagnosis that is any of Ehlers-Danlos that's anything other than based on history and examination. Although we are leaning into genetic tests these days to find out a little bit more about that. So that'll be fascinating, a fascinating one to track over time as well. But we can talk more about that one later. Okay, doke. Any parting shots from any of you guys before we close this up for this week? Those of us in the Pacific Northwest, including all of you guys all the way up into Alberta, make sure to go cover your plants before next week and cover your pipes. I thought I was going to get away all winter without putting covers on my hose bibs. But yeah, we're supposed to get down into the teens Fahrenheit this next week. So cover them up. Take care of your little greenery things. All right, you guys have been awesome. Thank you for your curiosity. Remain curious, take what you learn, and go help some people. You guys be well. I'll see you next week, and hopefully see you at the in-person course, February 10th and 11th in Seattle. Take care. You guys be well.